Hey, it's Patty. This is the third presentation in four that I'm going through in just talking about glial cell activity and neurological inflammation and other presentations that we see in connective tissue pathologies and how these are all connected. Part one and part two are really important. I know this one is labeled more of what shows up when you have a connective tissue pathology, and I know that a lot of people are probably very interested in that, but to really understand how to treat it, which is the next one as well, we have to know how we got there in the first place. And, part one and part two really talks about the pathophysiology of this neurological inflammation that can happen because of underlying connective tissue disorders and what astrocytes are, what microglia are, and why that's so important to the system for maintenance. So while I know everybody wants to know this piece of, well, what is it that I have? Knowing how you got there is actually really important as well. Talk a little bit about that in this presentation too, about treatment strategies, and then even more in the next one. So again, this is really what are we seeing in connective tissue disorders, and I'm skipping all of the basic information because that's part one and part two. So if you're wondering what a perineuronal net is, that's in part one and part two, and that's where all the basic information to get to really specifically talking about some of the pathologies that we're more likely to see coexisting with connective tissue issues. So please watch part one and part two. I would have put them all together in one presentation, but that would have been a very long presentation. So I skipped over all of the stuff that's in one and two, and now we're getting right back into bringing it all together. So I do really hope that if you haven't watched it, that you go back to watch how we end up with abnormal neurological inflammation, regulation, abnormal astrocyte and microglia activity, breakdown of the extracellular matrix of the blood-brain barrier or the basement membrane. But I really like this little graphic here. So this is from a McConnell 2019 article. I use a couple of graphics in here that we'll go through that's available and accessible. But it really shows you when there is an increase or in the blood-brain barrier permeability, that's what BBB is, you have this breakdown of the matrix and things will get through, and that causes the astrocytes to become reactive rather than helpful, especially if you get in that self-perpetuating cycle. So it ends up being chicken or the egg scenario, and you really have to work on both. You have to work on improving the permeability of the blood-brain barrier, and then improving the reactive astrocytes and helping to control and regulate those. But what's neat is you can see it. That's why I like this diagram, is you can see all the things that end up happening that we might see a little bit more in our population, right? Like neurodegeneration, we have small fiber neuropathy, demyelination, astrocyte degeneration, a lot of stuff that crosses over, epilepsy or seizure-like activity, that I talk a little bit more in part two, I believe it is, with the perineuronal networks, that it can actually cause hyperexcitability within these networks. And that's actually what leads to the seizure-like activity, which I will brush on today too. But there's a lot of these overlapping features that happen with the simple idea of things getting through the barrier and making the astrocyte and microglia dysfunctional rather than helpful, right? So we have to remember that the brain extracellular matrix and the basement membrane as well can both be influenced genetically with connective tissue pathologies, right? That's going to impact the efficiency of those barriers. So if you have a genetic predisposition, it can make it more difficult for the brain and the immune system to appropriately respond to inflammation or to injury or to infection. And injury can include anywhere along that nervous system tissue, so brain or spinal cord as well. When that happens, and you can see here, so when things get through the blood-brain barrier, it causes a reaction of astrocytes. And again, this is much more in detail in number one and number two, but astrocytes and microglia actually come in to help. But if they continue to work, they become more pathological in nature and they contribute to dis-ease states. And we see this a lot, right? We talk about this with mast cells. Mast cells are actually very helpful unless the communication becomes off and they're sending wrong messages. And the same can happen with astrocytes and microglia. Okay. So the bucket analogy applies to just about everything in life, right? So the more irritants that fill the bucket, and we're talking about the bucket of things that go into knocking on the blood-brain barrier's wall, of that neurological tissue, the more likely you can develop this astrocyte and microglia response, right? So we need to know what goes into the bucket. What are the things that are irritating the blood-brain barrier, that's breaking down the permeability, that's supposed to be maintaining a firm barrier so that things don't break into being exposed to the neurological tissue. So when you go from this helpful state to overactivity, it will create a pathological or a harming state for the system. When we talk about those perineuronal networks, and please go back and watch if you haven't, but it's like a lattice network around the neurological tissue, around the neurons that are in the central nervous system. And the perineural nets really assist in regulating the synapse activity. It has to do with migraine activity as well. But if this becomes hyperexcitable, which can happen if there's a dysregulation and things that break through the blood-brain barrier, it causes this hyperexcitable state, which can actually increase the likelihood of seizure activity and also migraine activity for some individuals. So this is not to say that everybody with a connective tissue disorder is going to end up with seizures, but for those that have other genetic predispositions as well, maybe to the health of neurological tissue and the risk factor of damage to that neurological tissue because of other factors, the combination might make it more presentable as seizures in one, migraines in another, more of degeneration in another individual. But this is the excitability state is those perineuronal networks. So if something comes in and disrupts the perineural networks, you kind of have a hyper excitable state or a hypo-excitable state. So more of that conduction problem. Locally at the tissue, and again, this is a little bit more in the second presentation, locally at the tissue, you can have almost like a glial scar. So you'll get a thickening or a border formation. So it's not really a scar, it's actually supposed to be protective of the neurological tissue. But if nothing is done to help reduce the irritation around the edges, or the trigger is removed, or the reason why it was building up in the first place isn't taken care of, it's going to actually start to reduce the mobility of the tissue surrounding it and the function of the neuronal tissue that's there as well. And it'll continue to this self-perpetuating cycle of inflammation and irritation, which we'll talk a little bit more about those anatomical components and what it might be correlated to in connective tissue pathologies. So we have this excitability problem in some people, and we have this anatomical scarring or adhesion problem in other individuals when things break through that blood-brain barrier that's connective tissue, and it might be less efficient. So this is from a Circle article in 2023. Minimizing scar formation would improve neurological function. It seems like really we have to drill these simple things in because I tell all my patients it's really simple, and also it's very confusing. But minimizing the scar formation, obviously, if we can reduce that activity that's happening, it's usually from this neurological inflammatory reaction, we can improve neurological function. So let's go back to what we're seeing in connective tissue disorders. So let's bring this back in, and I talk a little bit more about the MMP9s in the second presentation. The fact that we do see this with HSD and HEDS specifically. This is just for the confirmation again. So we see this with some neurological conditions as well, and we also see it with symptomatic hypermobility. So could we be seeing this in those with symptomatic hypermobility because we do have a neurological type of response and an MMP9 reaction because of breakdown in the blood-brain barrier already in those that were tested? And possibly, we don't really know if it's a cause or effect, but just again to confirm that there is a lot of overlapping within these populations, just to confirm, hey, I think that we're seeing the same thing here. We already see evidence of glial scar or border formation in those with HEDS, which I'll talk about a little bit. Is it the same thing? It really does sound very similar as I talk about some of these other conditions that we have in HEDS that we've put names to. So we'll go through those, but this is just that diagram that we had in the second presentation that shows kind of, and this is a very artistic representation of what happens, but we have this fibrotic scar that is made of connective tissue that will form a border around the neurological tissue. We have the astrocyte limitans border around that, and then around that is really irritated neurological tissue that can continue to react with the other nervous system tissue that's around it. So it's really a protective mechanism. It's a border formation, but everything around the border is irritated and aggravated. So it's problematic, but it's really trying to be helpful. So again, more on that in the second one. So here's where we're going to drop into diagnoses a little bit more. So tethered cord syndrome, and I'll have a whole nother presentation on what is tethered cord syndrome in our population, because it's not really like what we're seeing in the general population. And I feel like we say that about so many conditions when there's a connective tissue pathology underlying these other diagnoses, that it's tethered cord, but it's really like tethered cord. What we do know from the studies that have been done is that when they biopsy the tissue, there is abnormal presence of leukocytes, microglia, and mast cells. And that indicates that there is an immune inflammatory response that happens at the neurological tissue. So to simplify, and not bring all of my nerdy neurological stuff in here, just understanding that if somebody has a diagnosis of tethered cord syndrome in the population of a connective tissue disorder, that I am very hopeful that somebody has had the conversation of why is your immune system having a reaction, and why has it chosen your spinal cord to do so. So that's where I work with individuals of, can we calm down this reactivity? We know that there's abnormal microglia, mast cells, leukocytes indicate that there is an immune system response. So can we work on this inflammatory piece to reduce the localized reaction that's happening at that tissue? I do want to say, though, that we do know that there is abnormal neurological tissue response in those with connective tissue pathology. So typically when tethered cord is present, it's not one thing. There's usually a number of other things that are happening as well. And there could be a more acute injury that's happening locally at that area as well. So what I say is there could be, this inflammatory neural response that's simmering, right? That we don't know. Maybe there is something a little tight in the spine, and maybe losing a little bit of range of motion. And then we have this chronic stress and strain of the neurological tissue that we see with abnormal spinal cord motion in our population, which I'll talk about more when I really focus on tethered cord specifically. But basically, we know that within the HEDS population, the neurological tissue tolerates less load if you try to stretch it, even though it has the capacity to stretch more. So basically, the alarm bells go off much sooner, and you actually have adverse effects. So if you try to stretch the neurological tissue, even though it's stretchy and has abnormal movement compared to the general population, it gets angrier faster and more reactive faster. And you can end up with some of these inflammatory reactions from abnormal spinal cord movement. So I'm not trying to say that everybody out there that has tethered cord syndrome only has, some sort of inflammatory pathway with the immune system. I do think that there is work that needs to be done on the anatomical structure itself. And I've seen plenty of people that have very specific injuries that have happened, lumbar spine instability, something that's happening higher up in the spinal cord, pelvic malalignment issues. But there is typically a structural thing that's feeding into it on top of the inflammation. And then again, we typically see this overlap, right? This neurological phenotype that we've seen in HEDS is if you have one, you probably have a list of neurological involvement. And understanding what I talked about in the second presentation would help us understand that this isn't 20 different problems. This is one problem that can create 20 different diagnoses, presentations, however you'd like to label those things, is that there is actually quite a similarity, as I'll show you coming from the second lecture into this one, that with that neurological inflammation, that hyperexcitability, and the change in the structural components of neurological tissue, we can see so many different things pop up in different areas of the body. And this is just from that article from Pertucci in 2024 that looked at the neurological phenotype. And if you look at, and there's more than just what I kind of boxed out here, but we talk about these a lot, right? CCI or AAI, so the combination of craniocervical and atlantoaxial instability or upper cervical problems. chiari malformation and tethered cord, and I have those boxed out. And if you look in cluster 3, we have 75%, 60%, 55%. And if you look in the other clusters, we don't really have that high of a prevalence of those conditions. So we can see that in this neurological phenotype, we've got a lot of people that have more than one thing that's happening, right? And this might help explain it, that our neurological tissue is more likely to allow things through that shouldn't be coming through. And I'll explain a little bit more about chiari malformation and tethered cord in this presentation. And then for cervical stuff is actually going to be in its own eventually at some point, so you can understand the mast cell component of that area. But there is a reason why inflammatory reactions will lead to these things, or at the very least contribute, because there are other things that can cause this, right? You know, tethered cord, I've had patients that have underlying congenital spina bifida that hadn't been caught before, or occult spina bifida, and a number of other things. So there's other predisposing factors that can make you more likely to have these as well. But as you'll see, there is a similarity. You know, the tethered cord in our population has a neuroimmune inflammatory component to it. And I'll show you chiari malformation might as well. So again, what are we already seeing? In the article that came out by Severance in 2024, here's the really nifty diagram. I love diagrams, and I circled that area right there. So disruptions to the extracellular matrix may increase blood-brain barrier permeability. So if you have an extracellular matrix that is more prone to dysfunction because of genetics or other factors, then it's more likely to potentially break down from irritants, and it's going to change the permeability, and it's going to potentially lead to CSF leaks. So we have to remember that our dura is a neurological tissue, right? And the neurological tissue health is dictated by the state of our autonomic nervous system and our interaction between our nervous system and our immune system. So tissue integrity of these neurological structures are determined by the strength of those barriers. So again, if you have blood-brain barrier disruption that can be caused by abnormal connective tissue disorders and contributing factors, right? It's that bucket analogy. So you have a connective tissue problem, and what made your connective tissue mad, that's going to contribute to CSF leaks. And I can tell you that this is typically the story for individuals of multiple patches that have failed. And I'll put it this way, is that you'll probably have better outcomes if you have somebody also working with you on why your dura integrity has been compromised and working on the blood-brain barrier itself to help restore the kinematics between the systems. So this is the same conversation over and over again. This is neural tissue integrity can be compromised if the blood-brain barrier has been disrupted. Scarring response at the brainstem can absolutely happen in our population, and go through this just talking about scarring in general, and then something interesting about another diagnosis that we know. But we talk about the brainstem a lot in our population, near and dear to my heart, and I'll also show you a slide as to why it's so near and dear to my heart. And this is something that I now screen with all of my patients to see if there is brainstem involvement, not just from imaging, but also just on subjective information as well, because we don't necessarily see adhesions in our standard imaging that we do on individuals. We do know, though, that there's a difference in the spinal cord mobility in those with connective tissue pathologies compared to the general population. So, you know, in this article that came out a couple of years ago, what they said too is that this increase in spinal cord motion, especially in these areas, you know, the upper cervical spine, possibly the lower part of the spine as well, in combination with what we talked about before of tissue integrity, right? So we have this increase in spinal cord motion. It's not moving the same as what we would think that we would see in stereotypic motion at the spinal cord. And also, it doesn't like to be tugged on or pulled or stretched, but we have increased motion. That can lead to neuronal issue or nervous system tissue damage over time, right? So it can happen at the upper part of the spine, it can happen at the lower part of the spine. Of course, it can happen in other places too, but just because of the way that the system is set up and these force transfer components, kind of the hot spots of the spine, we tend to see a lot potentially in the brainstem and craniocervical area and then down lower as well. Interestingly, too, as we're talking about why is there scarring? Why is there adhesions that are happening around the brainstem, right? Like, why is this building up in that area? From another article that talks more about upper cervical pathologies, we see much more mast cell activity within that population. In fact, most people that have upper cervical issues within our connective tissue population have mast cell issues. So again, we're not talking about who's the chicken or who's the egg, but we're certainly seeing them together. We have those same neurological barriers in the brain, the brainstem, and the upper cervical spinal cord as well. So same tissues that we're talking about, same barrier systems that can have that breakdown effect if we have the connective tissue pathology and things that are making our connective tissue mad. So the issues with those barriers, as we talked about previously, and the breakdown, especially in our second lecture, can also affect the brainstem tissue as well. We talk a lot about the blood-brain barrier, but the brainstem as well, and it can also irritate the lower portion of the spinal cord too. So we can see this in different areas. We talk a lot about the neurological tissue of, we think, central nervous system, brain, it's brain and spinal cord, including the brainstem and the structures in between. Okay, so here's the interesting thing that I feel like maybe we should have a wider conversation of who we talk to within this study population or our researchers, because I just thought it was interesting. This is an article that's on chiari malformation specifically. So it's not on connective tissue disorders and chiari malformation, although we don't know if these people possibly had some. But what I just want to talk about is chiari malformation in general, because we do see chiari malformation, low-riding cerebellar tonsils, cerebellar ectopia. We see all of these things, so we know that there is something happening at the cerebellar tonsils, right? And at the brainstem as well, as we see, because when they did biopsies of individuals that were undergoing chiari decompression surgeries, they found arachnoid adhesions. They found thickening of the tissue. They found webbing. They found tonsillar gliosis. They found adhesions in what's supposed to be the opening and dural scarring. So I'll pause there and I'll say, doesn't that sound familiar? Doesn't that sound like some of these adhesions or scarring formation or the gliosis? I mean, it's a glial cell reaction. So when we're talking about chiari malformation, could a lot of this be actually also a localized tissue inflammatory response that's happening? And I would say for our population, I think it's something that we at least have to consider, that this could be part of the systemic neurological inflammatory reaction that's happening, because we see this crossover with things of neurological inflammation, adhesions, thickening, webbing, gliosis, scarring. These are all neurological inflammatory reactions. And yes, of course, it can come from the cerebellar tonsils being compressed in that area where they're not supposed to be, and from the friction and irritation. But we don't know what's a chicken and we don't know what's an egg. So again, just it's interesting, the similarities, right? So for individuals, I think that are dealing with chiari malformations, low-riding cerebellar tonsils, all of these things that happen in brainstem or in the cerebellar region, that we do have to think of screening for neurological inflammation, again, to be sure that we're getting all of the pieces, right? And we know that chiari malformations are more commonly found in those with HSD and EDS as well. So why is the brain stem and the brain important in this population? Well, I feel like the brain, a lot of us can figure out like, oh, well, we need our brains, right? The brain stem, though, and this is why I always check it with my population, is because it actually controls the autonomic regulation of the body. It can cause or influence the presence of dysautonomia. So a lot of individuals that do all that they can for dysautonomia and they don't feel like it's under control, and they've tried all the tricks that are online. They've worked with professionals. I always want to know, what's going on with your brainstem? Is it actually something anatomical that's going to be very difficult to treat without working directly on the brainstem? And from just talking, that can be more of the neurological inflammation or manual work with the brainstem, which we'll talk about. So the brainstem specifically, irritation here can cause or contribute the presence of brain fog, chronic fatigue, headaches and migraines, word finding issues, things like that. So again, we have to remember to screen for anatomical components. I don't throw anything out the window with an individual. I don't assume that it's any one thing that's causing something. I like to assume it's all the things first, and then we start to weed things out over time. I just want to make sure that we're not leaving anything out from this complexity of what it could be, and anatomical brainstem issues can be one of them. From what I've seen, this can very much contribute to the brain on fire sensation for individuals with brainstem compression, especially if your fire is starting in the back of the brain and kind of underneath. This chronic panic or despair because it's your autonomic regulation, right? If something is constantly pressing on your brainstem, it's going to send signals of fight or flight out, right? So even though we feel like we should be calm and centered and we're safe, the brainstem compression or the brainstem irritation can actually cause abnormal signaling to happen and can create this environment that you feel. It can be lead to seizure activity as well. I think that, of course, with the perineuronal network involvement, can very much make that presentation happen for some individuals. Motor control issues. So many things with motor control issues and brainstem, right? So honestly, I just assume most of my patients have something with the brainstem, and we're going to want to clear it at some point. I just think it's a common area for many individuals, and it seems to be a hot spot for where inflammation likes to build up, and whether or not it's the fact that we know that there is abnormal movement there, so maybe abnormal tension patterns that just chronically is building up without any potential injury or additional fuel to the fire of like an infection or chronic virus, or talk about those inflammatory pieces. Maybe it's this, abnormal mobility that we need to be trained out of or trained more functionally that could actually be contributing to because of the abnormal movement. But we can see motor control issues, so dystonia and things like that, and especially motor control issues if we have that perineuronal network activity and that hyperexcitability. I tend to see that combination with individuals as well, that they have more motor control issues or spastic-like movements or dystonia of the limbs when they have that combination of the perineuronal network irritation along with brainstem involvement. Breathing as well. I don't think that a lot of people know to ask about breathing as part of health. And I don't just mean, do you feel like you can breathe in and out? We tend to normalize so much or forget what normal might feel like. But some breathing things that could happen are feeling short of breath, that you can't take a full breath. One of my most commonly reported after I ask is forgetting to breathe. So realizing that you haven't taken a breath in a while, especially if you're holding your body in an unusual position. You are supposed to keep breathing without telling yourself to do so. And this is important, especially or for those that have failed breath work or hate breath work, is to understand that at least two of the centers that we know about, because we don't know very much about this, actually this piece of the body, two of those centers that are autonomic, so the parts that you're not supposed to be thinking about regarding breathing, are actually located in your brainstem. So for all the breath work that you're doing, you might not be able to get it to stick until somebody looks at your brainstem to make sure that there isn't additional help that's needed there. So again, when there is tethered cord issues as well, we have those two hot spots, right? So it's typically like the brainstem down to C2 area and then down at S2 or kind of the end of the phylum that tends to be hot spots for friction related, injury related, inflammation related activity of the neurological tissue. So a lot of people that have issues up here have issues down there as well. And we just want to make sure that if somebody has a brainstem issue, that we are making sure that there's not a tethering or an adhesion type of reaction that's happening lower down in the spinal cord. And that's why I think maybe we need some different terminology at some point, because I think that there's this wide range of what tethered cord syndrome looks like for individuals. And if we understand that it's a neuroimmune inflammatory response, that it's going to have this buildup phase and potentially an ease down phase and a build up and an ease down, that we might be able to address one and hopefully both down the road, top and bottom of that spine, for the best outcomes. We don't want to help one and then still have the pulling and the abnormal motion down at the other. Okay, so again, why is the brainstem important? And just to understand, the brainstem, I feel like somehow communicates with every single part of the body, right? So this is just a really neat little schematic, but it shows you all of the cranial nerves. Cranial nerves are super important. They help with vestibular issues. They help with vision. They help with eye movement. They help with taste and smell and all of those things. And also what's important is your vagus nerve is part of this as well. So when we talk about dysautonomia and the brainstem, we can be talking about trigeminal nucleus a little bit deeper, right? But we could be talking more superficially about the vagus nerve too. So we don't want to forget about the nerves that are exiting as well for those that have trigeminal neuralgia, facial nerve pain. You have to look all the way back to where it's coming from as well. So for those that have not had the best results working in trigeminal neuralgia or facial nerve pain or the vagus nerve, again, maybe we go back to the brainstem, trigeminal nucleus, see what's happening in those areas with somebody who's trained to do so. Okay, so this is an article from a while ago, still stands true in what I've seen today. In most cases, the morphology returned to normal once the stimulus was removed. So what the tissue looked like returned to what it was supposed to look like once the stimulus was removed, not the tissue. So I know that there are procedures out there that can remove tissue, and some people do need those. I'm not saying this is to prevent surgery for everybody, but to understand that the pathology that brought you possibly to that place, that's not necessarily changed unless somebody has worked on that piece with you. The stimulus has to be removed. This is just another, a couple schematics from that McConnell article. I really like this. It's got really, really good pictures in there. And I just got this beautiful piece of artwork for my wall at we just moved offices this weekend. And I don't have a picture, so I can't show you because I don't have rights to the copy that's available online. But in that, it shows it's just a picture of an astrocyte and it's a picture of a blood vessel. And you can see perfectly where the astrocyte comes down and the end foot hooks up to the blood vessel. And that's all that's in the picture, but it shows you the neurovascular connection. Okay, so this picture on the left-hand side, let's see if I can use a little laser pointer. So this shows you an astrocyte right here, and this is the blood vessel, right? So we have astrocytes that line up here, and the astrocyte end foot, these guys, so you can see a big end foot right here. These astrocytes are what are communicating with the blood vessels in the brain. So for individuals that are having neurovascular issues, we want to make sure again that that blood-brain barrier is very healthy, because disruption to this can cause the astrocytes to get mad and send wrong signals to the intracranial vasculature. Okay, so this is why I always seem like I'm talking about the same thing, but it's because we have to clear this neurological inflammatory response first, before we think about doing stuff to the specific vasculature that's in there. It's called neurovascular coupling. It's where the neurological system meets the vascular system. Happens all throughout the body, but in this space, the astrocytes are what are speaking to the cerebral vasculature and regulates the resting tone, which other nerves do that in other parts of the body, just so that we understand. So we have to remember inflammation and the state of the autonomic nervous system will regulate the tone in vasculature, which includes the floppiness and the squishability and reaction to compression in these structures. So I hope that we are all talking about the health of the neuroimmune system when we're talking about insufficiency inside the cranium. Okay, and then this is just this where we can see the self-perpetuating cycle. So astrogliosis is just riled up astrocytes, right? Um, and what we end up with, and this is all where everything can feed into each other. So it doesn't really matter who started all of it. Like we have to work on this, right? But we can have that blood-brain barrier failure that happens that is going to impair the neurovascular coupling, right? So we just have to remember all of that as we're working on treatment plans for individuals. That again seems like I'm always talking about the same thing and I'm always pointing my finger at the same thing. But what I'm trying to say is we should always be screening for this as part of that bucket piece, right? We talked about all the other things that go into the bucket, this abnormal spinal cord movement and things like that. But there are other things that can irritate the astrocytes as well. Okay. So what do we know about glial recovery? Well, mild to moderate forms of this reactive astrogliosis seems to resolve if the trigger is removed, right? So the trigger has to be removed though, and that's the key. Again, not the tissue changed, but if we're talking about changing the pathology that brought us here in the first place, we have to remove the trigger or triggers. More extreme activation of those astrocytes responding to tissue damage is going to form the glial scarring response or the border formation. That can be longer lasting after the trigger is removed. There's not much in the research on long-term recovery on that. That was from 2013. So in other words, you can reduce the astrocyte reaction, so that hypersensitive, irritated area, painful area, but we don't know if we can actually change that border formation that happens. I am curious if this is actually what microcurrent is doing for my individuals, and I'm seeing the change in the neural mobility. But we do seem to be able to reduce the astrocyte irritation at the external layer in individuals that are working on the neurological inflammatory piece, right? And perhaps the microcurrent and maybe other things I don't know about could also be restoring that border-like formation. Overcoming the physical and chemical barriers of the scar are becoming possible. And this is important again, because I do think that working on these requires a combination of physical manual modalities and also reduction of the neurological inflammation. It's really the component of both of those that we're seeing the most benefit from. Axons that have been chronically injured or irritated can grow through a peripheral nerve bridge, so like an adjunct nerve bridge, and restore a small amount of function in the chronically injured spinal cord. So this is from spinal cord injury, but it's just to show that we are seeing benefit when, through neuroplasticity and neural growth. And could we speed that up if we normalize the conversation in our neuroimmune system? Possibly. Okay, so here's the the big slide, right? And I said that in the second one, second lecture as well, is that you have to remove the trigger. So what are your triggers? Okay. So this is not an exhaustive list. I'm sure this is going to continue to grow and grow and grow as we understand neurological inflammation. But some of the things that we do know that lead to this, and I don't think I have even dysbiosis on this left side, which we'll get to in a moment, but we even know that changes in the gut microbiota actually change what's happening at the blood-brain barrier. So that's also interesting too. So everybody is different, and this is why it really takes a team between the patient and a provider, or the patient and a few providers, to figure out what the appropriate things to work on in that bucket are to be able to reduce the physical manifestations of the symptoms, right? So yes, we can have brain and spinal cord trauma. We always have to be screening for that. There can be a physical reason why somebody is having this neurological inflammatory reaction. We can't assume that it's all these, chemical toxin irritants that can be happening. CNS ischemia, so anything that is reducing the oxygen within the central nervous system. And I will say, interestingly, this neurovascular problem and the article that just came out with that was written by Nicole Frost, and I apologize, I don't remember the other author, just in 2024, or yep, 2024, the end of 2024, that talked about the neuraxial disorders in connective tissue disorders, or EDS, is that we're seeing this difficulty to stabilize neurovascular responses, that plumbing is difficult around the neurological system. So if plumbing is difficult, we can have difficulty transporting oxygen to these tissues to be able to offer a healing environment. So for me in my field, that's manual work. I know that others have their other ways of dealing with it, but there are some people trained in working on the manual component of improving the plumbing and blood oxygen to neurological tissue. Infections, chronic infections can really wreak havoc on the nervous system, on neurological tissue, because again, this is constantly bombarding the blood-brain barrier, right? Inflammation as well can do that. Any reason for inflammation that might be there, even from injury and things like that, if that builds up and crosses through the blood-brain barrier, we don't want to see those things in there touching the neurological tissue, but it can. Microbial infections as well. Environmental toxins, especially mycotoxins. And I'll say, like, mycotoxins is in the literature. There are many other things that can irritate the tissue from the environment as well. It can certainly be environmental toxins, like we think of plastics, pesticides. It can be chronic viruses. Thanks to COVID, Epstein-Barr, we are understanding that a whole lot more clearly. But those sort of environmental toxins and viral loads, if you don't have a great barrier system, it can turn into an open door party. So if you let one in and it's increased the permeability, it can actually let more things in. And that is why we see a lot of people with connective tissue pathologies that seem to build up a rap sheet of all of the different toxin exposures that they've had. It's kind of like the diagnoses, right? If you let one in, you're going to let all of them in. If you have one neurological diagnosis, if you can see now, it would make sense why you have so many, because they all stem from a similar place of uncontrolled neurological inflammatory reactions and instability in the immune system at the level of the neurological tissue. Okay, so yes, toxins can be a big component of what's happening. It's not a foo-foo part of it. I know that there's a lot of individuals that don't think that this has a significant impact, and I would disagree. And I do think that the environment is actually a big part of why we see more of this condition. It's actually not because we have more people with the genetics. It's actually because if you do understand the barrier component, we have more people that are symptomatic because there are more toxins and things that are trying to get through those barriers. And we just don't have a great defense. You can learn a great defense by working with an individual, but not until you're taught. Chronic habitual alcohol use can also cause astrocyte dysfunction in individuals, and I'm excited to eventually talk about this in more detail down the road, but for now, just to know that either binge drinking or chronic habitual alcohol use, even at low levels, and I'm not demonizing this because for a lot of people it regulates the autonomic nervous system at the end of the day. But if we can find other ways to help regulate this that doesn't also cause the neurotoxicity that can break down those blood-brain barriers, that would be great. Tumors, metabolic disorders, seizures, and neurodegeneration, that's a little bit of that chicken or the egg question with those things, because we know that astrocytes can get caught in that cycle again that causes seizure activity in themselves, and seizure activity can cause astrocyte dysfunction. So just to understand that astrocytes should be a conversation if there is seizure-like activity, right? And then emotional trauma is something else that's in my picture here that I put in that is not necessarily in the list that's bulleted here, but it's also integrated and digested by the autonomic nervous system, and you can have astrocyte and microglia responses as a threat response to the neurological system. So that does tend to go into many people's buckets of the combination of how did I get here? It's usually not one thing. There's usually a handful of big things that are in the bucket that will need to be worked on. Okay, so treatment. There's not a whole lot out there as for treatment, but I wanted to talk to you about things that I see working for individuals and have talked to other providers about that's working to hopefully have other people come up with other ideas as well, or maybe even comment on this video to say what has worked for you in regards to these treatments. And the first thing I'm going to talk about is the anatomical scar response or border formation at the local tissue. So not necessarily the excitability, but that tissue hardening, thickening, restriction, the astrogliosis that happens in the change in morphology. We can do specifically glial directed therapies. And here's the problem. So if you listen to part one, we didn't even know astrocytes were a thing until not too long ago. We actually thought they were just filler in the brain, which is just so silly to think of now because they play such a huge integral role in neuroimmune responses. But we thought that they were just base filler in the brain. Astrocyte dysfunction are related to other neurodegenerative disorders like Alzheimer's disease, Parkinson's, Huntington's, MS, things like that. And there's a component of a genetic link to autism. So there's a lot of crossover with this astrocyte involvement and what we already are starting to see as neurodegenerative conditions. But if you look at the treatments that are available, there aren't many treatments available because we didn't know what astrocytes were. We didn't know that people were having astrocyte problems. So now we do. So now it's going to take a while. It's going to take a long time for the studies to be done. And then after that, it's going to take a long time. I think it's something like 20 to 30 years from things to go from the research to mainstream medical. So sorry, but we're not even really in thorough research phases yet. So that's why the patients are probably going to know a little bit more than the general medical practices for the most part now. You'll find some good ones out there for sure. There are some glial directed therapies. So low dose naltrexone specifically works on microglia, right? There are, it doesn't look like I wrote it in here, but there is mestinon. So mestinon, I think it's actually, I talk about it more in my fourth, a little bit more through treatment there as some of the options. But mestinon is a new one that they're trying to use. They use in different neurodegenerative disorders, but I've had some patients try that as well. But it's very few and far between pharmaceutically for what we have available for glial cells particularly. And then P-directed therapy. So I've heard a number of patients that are like, why did doxycycline work for me? And it might be because it works backdoor on the MMPs, which can, if you work on the MMP presentation, you can work on reducing the neurological inflammatory reactions from a backdoor approach, right? Neural manipulation, brain manipulation, these are things that I use in my office. There are a few different schools out there that teach this. And I don't necessarily want to promote one or the other. I was just taught through Dural. I know that there is IMT is another one, applied kinesiology. Please write any other ones that you know of in the comment section if it's worked for you. But there are people that are trained to work on brain tissue and neurological tissue throughout the body in a very gentle way to help free up adhesions around the dura to release the brainstem. There aren't many, but they are out there. Frequency-specific microcurrent. I actually use this as a great modality. As I said before, I actually think this might clean up a lot of, we call that scar formation, the border formation, the fibrosis that happens, whereas we have other ways that can calm down the inflammatory irritation. I think the microcurrent may be working on the fibritic part, the actual anatomical cell changes, the morphology. Perhaps that's what is helping individuals come into remission from tethered cord, brainstem irritation, brain involvement that I've seen that have used the microcurrent. I want to be very realistic about this though. The frequency-specific microcurrent I think is absolutely amazing, but it is not curative because again, if you are using microcurrent and you are still living in a moldy environment that is your trigger, it's not necessary. You have to remove the trigger. So you really still have to do work on that component that's causing the inflammation. And from what I've seen in the patients that I have had use it, it typically works better after you work on why you're inflamed. So patients do so much better if they've already gone through detox or had antivirals. they do a lot better with the microcurrent. So if considering microcurrent and you feel like you have this neurological inflammation, please make sure that somebody is working with you on the inflammatory piece to make sure that you're treating it from all aspects. Similar to microcurrent is the pulse electromagnetic frequency. So it's through magnetics. And this is something that I haven't played with my unit. I just got it in, so I can't comment on this, but I can comment that providers that are more well-versed in microcurrent than I are seem to like it a lot. And that's all that I can say about it. So maybe I'll have another talk at some point on microcurrent versus PEMF and what I found, but apparently it does seem to work and it might be more affordable for individuals as well. In talking to those who use PEMF, and microcurrent and make the devices, there is still a bias towards the microcurrent specifically as being more immediately effective, although the PEMF might work the same over the long term. We just don't know. And then fascial counterstrain. So I was talking before about that plumbing problem that happens in individuals. So perhaps we're seeing this neuraxial dysfunction, this neurovascular, interstitial stasis, we call it. Could there be restriction and difficulty flowing out from the neurovascular structures? And I see this a lot with individuals that have this inflammatory reaction. And fascial counterstrain is one of the best things I have found in my personal practice to be able to use for this. But again, there are other techniques out there. Feel free to write them down in the comment section, but make sure you're letting us know neurovascular drainage. I've used this, so we know what worked well for you for what. The fascial counterstrain has been very helpful, especially when really trying to focus and localize treatment. Okay, so reducing irritants. I cannot tell you how to do that. I probably will try to in some way at some point through these talks, but it's just very different, right? So working somebody through their reasons for inflammation can look very different depending on so many different personal factors, financial capabilities, how their system is responding to things. So this is not a lecture on how to do it, but just to understand that chronic viruses, toxin exposure, any molds or chemicals, pesticides, things like that, tick-borne pathogens, emotional trauma, chronic stress input, anatomical influences. So we talked about the local tissue trauma, so spinal deformities, chronic concussion symptoms, anything that's happened to the neurological tissue physically, mast cell responses, abnormal mast cell responses. We're still talking about the same neuroimmune connection, autoimmune contribution. So if you have an underlying autoimmune pathology that might be feeding into this as well, or chronic infections, all of these things need to be looked at. So this is really the big thing for the inflammatory or the trigger, removing the trigger, is that we have to go through and make sure that we've addressed each one of these. And I'm probably missing some on here, right? But just what are the reasons for your neurological inflammatory response? And then how do we address it with you? And it's going to look very different person to person. Okay, so, and here's some stuff that, if we're talking about the connective tissue pathology, so the connective tissue itself, like improving the blood-brain barrier, I don't know. I don't know. I can offer some suggestions, but there's no research on it, and hopefully there will be over time. But we talked about the permeability being a problem of the blood-brain barrier and things getting in easier. And if you have a connective tissue disorder, then maybe it's easier for things to get in. So how do we make it less easy? How do we improve the state of the blood-brain barrier back to somebody's baseline where it's been broken down over the years? I'll offer some suggestions. Again, you can put in the comment section, blood-brain barrier, strengthening suggestions, whatever it might be. We just don't have research on it, but frequency-specific microcurrent, I think that could be helpful for some in reducing the inflammatory reactions, stabilizing mast cells, supporting the immune system, and then also reducing neuroinflammatory changes that happen as well. Not curative, but I think it can help restore tissue mechanics. Again, PEMF, I don't have that much personal use with it, but it's similar to microcurrent in its effects. Red light therapy is really like a cellular healing level type of modality. And I have had individuals that seem to respond really well to this. I know that there's information out there that say that it causes mast cell degranulation. Interestingly, I've typically had positive feedback from individuals regarding red light therapy that do have mast cell activation syndrome. Most of my patients do. Um, and these are all things too that you can modify the exposure to. So red light therapy, you do not have to do it for 20 minutes when you start. You can integrate into it. There are peptide therapies. So BPC 157, TB 500, BPC 159, I just saw. I'm not going to go down the rabbit hole on that, but could that be effective? Maybe for some people it could be. Enzyme therapies as well. So things like beta glucan is something else that we're thinking about for connective tissue. So maybe we don't have information on this. We have a lot of people trying things. But again, to start putting together what are the things that I need to help repair this system, that I have neurological inflammation, blood-brain barrier disruption, and tissue dysfunction, is you probably need a little bit of something for everything. And then vitamin C is on that list just because we know it helps build collagen, so it could be helpful to help build collagen for some individuals, right? Ultimately, in the end, we have to keep the extracellular matrix or the connective tissue clean. We have to clean out those barrier systems, and how we do that is by not letting things in. So that is impossible to do, just so you know. So you purposely try to keep the things out, whether it's changing work environments, so those stressors, those sort of toxins, changing your internal or like the environment that you live or work in, if you feel like it's a moldy environment. And these, I'm saying this very lightly, it is a very tough decision. It's very tough to get through if you do feel like environment is affecting it, but it can be very beneficial. But we really have to make sure that we're constantly siphoning things out of the bucket. And then what are the things that you've learned through the journey that are effective for you? Are you somebody that owns a PEMF device? You do red light therapy and you do a detox once a year, no matter how you're feeling, because you know that that helps keep your system clean. And again, it's different for everybody, but it can be helpful along with addressing the neurological tissue specifically, depending on where it's irritated. Okay, so summary. Connective tissue pathologies may not only cause the issues of the extracellular matrix with our classic presentation of connective tissue, but also with brain and spinal cord as well, right? So we have this response that happens at the brain, so brainstem and spinal cord, especially in the craniocervical region and potentially at the lower part of the spine too. It's going to be less efficient and more reactive to irritants. So it's going to get super irritated. Those helpful cells, the astrocytes and microglia, they have difficulty turning off. They're going to cause local and more peripheral issues farther away throughout the nervous system. When that becomes dysfunctional, neuronal and brain functioning both, you have this local glial cell border formation, or this scar or adhesions that develop around those areas to help protect it. And then understanding this, finding the appropriate treatment methods can help those with seemingly global nervous system issues that also suffer from brain involvement. So you have a lot of nerve stuff going on. You also have brain fog, word finding issues, this combination of like cognitive along with like neuropathological. We want to think then, like, is this something systemic, and could it be this neuroimmune response that you need somebody to help you calm it down? So again, to kind of even summarize this more specific information, just a reminder that abnormal perineuronal network activity that happens because of disrupted blood-brain barriers can actually lead to seizure-like activity, and working on that inflammatory component can help reduce that for some individuals. We have tethered cord presentation, which could actually be overlapping with this glial cell or glial scar formation or border formation that happens. So we have to make sure we know it's a neuroimmune inflammatory condition as tethered cord in our population. So we have to work on the neuroimmune system to reduce the reactivity at the local tissue even as well. Okay, chiari malformation or the cerebellar tonsil issue, and we see adhesions at the brainstem, adhesions all throughout. Remember, adhesions are potentially responsive to trauma or inflammation as well. So we have to make sure that, again, the neuroimmune system is addressed for those that have chiari malformation. We know that dural integrity issues that can lead to CSF leaks can happen more from impairment at the blood-brain barrier. So yes, a connective tissue disorder can facilitate this, but things happening to your connective tissue that is disordered can facilitate this. So if we're looking at any treatments for CSF issues, we want to make sure that we are reducing the other irritants at the blood-brain barrier for the best outcomes, right? So all of these things considered, we just want to remember that we have to treat the local tissue. So we do need somebody to work manually on the local tissue, the adhesions that are forming, the neurovascular movement that's happening. We need to make sure that we're working on the neuroinflammation that's happening as well. So we have to make sure that's like a whole systems effort, that if somebody is presenting with a diagnosis, it's important to remember it didn't just drop on them from outer space. Even tethered cord, upper cervical instability, chiari malformation, it didn't just randomly appear one day. To be able to treat it most efficiently, we need to know why it eventually appeared and the things that made it eventually appeared. That becomes the treatment strategy itself. So hopefully that makes sense, but also to show you all this overlapping explanation of it's as simple potentially for a lot of people as your connective tissue disorder involves your neurological tissue. Stuff gets through your neurological tissue. It makes your neurological tissue mad. We have to make it less mad so that you get rid of a lot of these diagnoses or symptoms or bring you into remission or reduce things for you. So super simple and super complicated at the same time, right? Okay, so lots of different references. That bottom one, that McConnell, I really like the visuals from there. But there are quite a few different articles that are out there that really try to explain why astrocyte and microglia dysfunction is really important to understand. And I think it is especially for our population as well. It's very similar to the mast cell component in the rest of the body, and we just have difficult time regulating a lot of this stuff because we have barrier permeability issues. All right. In the next one, in the fourth presentation I'll talk a little bit more about treatment strategies in terms of more of herbal remedies, some of the other stuff that we have out there. So hopefully much quicker than the last two have been. All right. Thanks for hanging in there.